couple of days, so bear with me. If you have any questions, I'll try to answer. But one thing I always do is like I'll go over it, but you know, we might not remember this in 2 weeks when we might be seeing them. So I always remind everybody policy and procedures. Does everybody know where to find your policy and procedures? Yeah. And when you log in on the UCare links, on the right-hand side, very far over, there's like the most frequently used tabs. Nursing manuals is there, so you don't have to scroll all the way to the bottom of the page or search it or whatever. It's right there. And obviously it's a very large document, so if it's a last-minute planning, you don't really have a lot of time to read it, but critical points is always good to look over, because they have some good information on just some of the most important things out of the policy and procedure that you would need. So for our department, we do see a lot of chest tubes, but we don't set them up. They get set up in intra-op. So it's actually really, really good to know how to set it up. So they always come out, they'll be in like a big box, and then the tubing is gonna be folded in it as well. And on the back, there's gonna be this little water, like sterile water that you're gonna use to put into your chest tube. There's also instructions that are stuck to the chest tube if you forget how to do it. It's very visual friendly, so if you do forget, it's right there. So you take this sterile water and you inject it into this blue port. And this blue port, do you know what else you hook up to this? The suction, yeah. So before, obviously, you hook up your suction, you want to make sure you fill it with the water, and it's all the water in this is the exact amount that goes into the chest tube. And then it'll just fill up at the bottom. Now, how would you know that you have an air leak? Yeah. So obviously, let the team know if there's a suspected air leak, to let them know, you know, what they want to do. I've been in situations that they want to leave it, but I guess moving forward, we'll see what it's like with our patients. For new cases, you definitely want to tell them. And then up here, this is your dial for your the centimeters of water, so the suction that they want it on. You can, and then there's just a knob on the side. You can turn it to adjust it to -10, -20, -30, or 40, just on the side here. And then once you hook in your suction, you'll see an accordion show up here, and that will tell you that, yeah, it's working. The patient's getting the suctioning and the fluid coming out. So it's gonna be hooked up to the patient, not with this white port, but with this end. We never clamp our chest tubes. You don't want to force the fluid to go down like we do with the JP drain. You just kind of, drain it with the tube. So you have a patient that you need to switch out to the atrium. You will want to, before you do any switching out, you want to have your atrium pre-prepared, so filled in with the water, and obviously sitting next to you, being ready to go. It'll have the tubing, but you won't need to have the tubing if you're just switching it out. So then what you do, it's the only time really you clamp, because you don't want to open it up and create any airflow there. So this is where you would clamp, and you just unhook right here, and then you hook in your new chest tube and unclamp, and then obviously discard the other one. This little port here is also used for samples, so if your doctor needs to get a sample, you get that from there. You always want to have one of the blue clamps available at the bedside, and other supplies included would be gauze or Xeroform petroleum jelly. And do you know why we would have the petroleum jelly?
Seal.
Why would you?
It's dislodged.
Thank you. Yeah, so if your chest tube comes out, if your chest tube comes out, you want to have that jelly ready, the petroleum jelly, to put it on the site right away to seal it and then obviously you page the team and let them know. If also on transport, if anything gets pulled, broken, ripped, unclamped, that's where you have that traveling, the little blue, I don't know what that's called. The little
Clamp.
Yeah, the clamp. Then you would use that to quickly clamp at the site if you still have a chest tube left. So that, yeah, you'd want one of these to quickly use for clamping for transport if something should happen. Pneumonectomies. Do we hook pneumonectomies up to suction? No, that's right. Now, we used to have, and I think we still do, which I know this is really far away, but on the policy and procedure, it's a different type of chest tube because it doesn't have a port for suction at all. We, a couple months ago, have been on back order of those chest tubes, so we've actually had to use these. So it's really important if you have a pneumonectomy that everything is done to block off this section so nobody is tempted to do section, and definitely let it known that it's a pneumonectomy, that we're not putting it to section. Questions about the chest tube so far? Okay, so that's kind of the most important things. The petroleum jelly, knowing if there's an air leak to call the team. Yeah, never clamping. And also notify your provider. Obviously they'll have orders for when to notify them on how much fluid puts out, but if it's over 100, you'll want to let them know. And definitely if you hook it up and it fills all the way up, that's not a good sign. So definitely pay attention to that. Okay. Move on to trachs, everybody's favorite. Okay. So, you know, most of our patients, we're very lucky if we have new tracheostomies that are going to get created, they go direct to the ICU. Again, we don't know what our future holds, so we might actually have to care for them. And in that case, the patient may not come out with a trach caddy. As we know, with our chronic tracheostomies, if we see them in pre-op, we have to get a trach caddy and get everything set up, and they're supposed to go to the OR with it, and then they come out to PACU. It's all set up and ready to go, and then they go to the floor, so it follows them throughout their whole stay. But if they are not coming from home and they're getting created in the OR, then I highly doubt the ORs will prepare them, so it's our responsibility to get it ready. These come from material services, so if you use one, if you're going to grab one, make sure you let whoever replaces your materials to get a new one to replace it. And not always, I've heard that materials have been filling them up for us, but not always is that the case. So if they do, that's awesome. If they don't and it's empty, not to worry, we can get all the supplies. So on the back of the trach caddy, usually we'll have a bedside checklist. And this might not always come with the patient or with the caddy. So if that's the case, you go back to your nursing manuals, and on the very last page, it tells you what supplies you need for your trach caddy. So that's always accessible for us. As for the emergency airway access, this is the emergency airway access form. This has to be filled out for every single patient that has a trach or a laryngectomy, because obviously we need to know which one they have, because that changes the way we do our emergency airway for them. So for new trachs, when the surgeon comes out, we want to have the paperwork ready for them to fill out. And then patients that come from home, a lot of the time the patient will be able to tell you what it is, so then you just need to get the doctor to fill it out so that it's ready. Every unit should have them. I'm not sure where you guys hold your forms, but we have them in our pre-op area. And if not, again, the policy and procedure does tell you what the form number is if you would need to order more. Okay, so for the trach caddy, what you normally need to have is your suction tubing. I don't know if this one has it all filled out, but they want the little bullets, the normal saline bullets, a 10 cc empty syringe, which I think might be in here. Yeah, you want your suction tubing. We have some masks here, which is awesome. Some surgical, the suture removal kit, and you want a mask, like a simple mask. And then you want your Shileys. And the Shileys, you want the same size that the patient already has, and you want one size smaller. And the obturator in the materials list, it says the obturator goes in here. It's actually in our packaging for each of the trachs. So those you already have. And obviously that goes with the patient. And I like the masks, which they're not on the actual supplies, because if you are doing any suctioning, I definitely highly recommend you do some droplet precautions there. Now this goes on the back of the patient's, because it travels with the patient, so it goes on the back of the bed. This is only for emergency. So if you are going to be doing regular suctioning or regular trach care for your patient, you really should have separate supplies available for you at the bedside, because anything you use on here, you'll have to replace right away, and it can get forgotten. So it's important that we treat this as our emergency resource. So little extra information about the trachs. If you have a trach that is less than 5 days old and your patient coughs and it comes out, what do you do? Do we put it back in? Do we put it back in?
Put the obturator in the hole.
But does the nurse do that?
Well, if the patient's occluding the airway.
So what I read in our policy and procedure is that we actually want to start providing airway, bagging them or giving them any type of oxygen and calling for help. And it's meant to be the surgeon or whomever the providers to actually replace that newer trach. Anything over 5 days, let me open up my policy and procedure so I'm not giving you the wrong information. I just read this not that long ago again. But if it's over 5 days, I think it just depends on the patient's, like how stable they are and how much they're occluding. And then, what page was that on? See, it's so many pages. You have to like flip through to find everything. So this definitely helps to talk about it. So it's over 5 days. Oh, that's about trach changing. See what I mean? Maybe let's just look at it. That's what's sectioning.
Were there vacations?
Sorry, you guys. I was just reading it and I can't find it now. Okay, well, I can't find it because the policy and procedure is 20 pages long. But you do have all the information in there for more detail, but there was a difference with 5 days, like over 5 days, you could potentially, unless you have resistance and difficulty, you call for help, but you could replace it. If it's less than 5 days old, from what I remember reading in this, is that you do have to have a provider that does it. Just because they're brand new, you don't want to cause anything.
Does the ICU kind of keep track how old the stoma is? So they know what to do in an emergency, that they'll say, oh, this is day 5.
Yeah, they usually report.
Yeah, because I think new trachs stay for a little while in the hospital, so they would know. For chronic ones, yeah, as long as they've had it done here, we'd have that documentation, but the patient might even be able to tell you how long it was that they've had it. But it definitely, 5 days was something I saw in policy procedure that was really important to note that if it's less than 5 days, definitely have the doctor there and available. You can provide air support, obviously, through their stoma if you need to while you're waiting and calling for help. Or if you are going to do it through the mouth, you have to cover the stoma. They just said a 4x4 gauze is enough to cover it, and then you give air through the mouth. Unless it's the laryngectomy, then of course it's all through the stoma. For suctioning, for a responsive patient that is talking to you, have them do 3 to 5 big deep breaths of air with the trach tent over their trach. Big breaths before you do any suctioning. And if they're not responsive, you can put an ambu bag over, give them 3 to 5 big breaths, and then do the suctioning. Those were kind of the 2 main things also I took from that with the suctioning, and as well covering droplet percussions. Trach ties or trach care is done every shift. Trach ties may be done every 24 hours, just kind of depending. Trach care should be done every shift. Cleaning, changing the actual cannula, the trach is every 24 hours, or PRN if it gets dirty more often. More questions? The trach stuff is kind of hard because we don't know. We just don't know.
Mm-hmm.
But I'd say the most important to take from this is the trach caddy. And then all the other information, well, you can have fun looking through it like I just did. As you saw how long it took me to even find what I was trying to find, and I couldn't find it. So, yeah. Yeah.
How often do you guys at Moffitt see like trach?
Ours go in waves.
Okay.
We probably haven't seen some in a couple months.
Okay.
And then there was one time we had like 7 in a week. So I feel like it's really unpredictable.
Okay.
Yeah.
All right.
Yeah, I've gone over this with a lot of people a lot of the times, but I feel like this always gets forgotten somehow. And it's important to communicate with our OR because they might not think of this as important because they have everything in the room, they just kind of do whatever, but that they know if they're an inpatient or an outpatient that they please bring out the trach caddy with them so that we don't have to make a new one if they already have one. Just because it's a pain to get the emergency form filled out.
Mm-hmm. After the fact.
Yeah.
Yeah.
Mm-hmm. By far, that is the most important thing you need to have is that emergency airway form. Yeah. Okay.
Thank you.
Yeah, like I said, if you have more questions, everything's in your policy. Yeah. Okay. Documentation. Maybe I'll wait for Christina.
Yeah, let me text her real quick and see where she's at. Let me stop that real quick.